This session الأستاذ الدكتورة هبة شفيق أستاذ جامعة طنطا هتكلمنا على Post-operative surveillance. اتفضل يا دكتور.
Post-operative surprises. In the performance of the strabismus surgery or any other indication, complications occur if the surgery is performed in sufficient number of cases. This means that surgical complications can be eliminated at least on statistical basis only by not doing. Therefore, it's true that the surgeon performs surgery enough times a complication will occur. However, whether or not complication is said to occur depends on the surgeon's definition. To establish better foundation of the complication, it's appropriate to discuss criteria for success. A perfect result for strabismus surgery could include the following: minimum immediate post-operative discomfort, no apparent conjunctival scars, normal palpebral fissures, normal versions and ductions, orthotropia, equal or near equal visual acuity, normal stereo acuity. Only rarely the perfect result attained because the patient who requires strabismus surgery rarely has the motor and sensory potential for attaining such results, except perhaps for a patient who has intermittent exotropia and with normal stereo acuity. In practice, although the intermittent exotropia patient potentially may be one of the most likely to attain perfect results, often these results are not achieved. This may be for the same reason that the patient developed intermittent exotropia in the first place. If a perfect result is not attained after strabismus surgery, what then? A reasonable goal for strabismus surgery should be established to determine a basis for what could be termed an acceptable result. For example, an acceptable long-term result could provide the patient with improved function and or appearance without introduction of any other complicating factors. Because complications or the potential for complications are an unavoidable part of the strabismus surgery, guidelines for treating or avoiding these complications should be established. Each surgeon should acquire and maintain sufficient skills and have sufficient knowledge of his patient, the reason for doing the surgery, and should prepare both himself and the patient preoperatively in light of the patient's specific needs. The surgeon and his patient should be then maintain realistic expectations as regard to the outcome of proposed strabismus surgery. Preoperative informed consent obtained from strabismus surgery should include these potential complications. Denial of a complication by the surgeon is guaranteed to exacerbate the problem in the patient's mind. The best way to deal with a complication is to recognize that it exists, convey this awareness to the patient, and implement a plan to remedy the situation. Here in case 1, a child patient, 1.5 years old, with alternating esotropia, about 45 prism diopter, that appeared in the 3rd month, with inferior oblique overaction, more in the right eye. Refraction was plus 1.5 diopter in the right eye and plus 2 in the left eye, with normal fundus bilateral. The patient had bilateral medial rectus recession, 6 millimeters, and inferior oblique recession. 2 days post-operative, there is 10 present diopter residual esotropia in the right eye with no inferior oblique overaction. The surprise wasn't for me, the surprise was for the patient. The father of the patient wasn't satisfied with the patient and told me that the child eye were not corrected and it's as if he didn't do surgery. From this, we learned that in cases of congenital esotropia, we must tell the patient that between 80 and 85 of post-operative alignment will be between orthotropia and 10 prism diopter of residual ESO, and that motor alignment will be considered satisfactory. They also have to be told that the most of the children will need more additional surgical procedure months to years later. Maybe new problems may appear as secondary E or V pattern, dissociated vertical deviation, or recurrent ESO, or even a consecutive exo. Finally, the patients are told that the children treated with congenital esotropia should be followed up by ophthalmologists till the teen age. Families are told that we will do 100% effort to make the present operation the last one, but realities may not deal with these ideals. Case 2, female patient, 20 years old. She had intermittent exotropia with distant angle 50 prism diopter since 3 years. She had poor control, visual acuity was 20/30 bilateral. Refraction was -2.5 bilateral. She had bilateral lateral rectus recession, 9 millimeter. She was told that the recurrence rate is high and that she needs to wear glasses. Here is the patient. In the middle, we can see that the patient is orthotropic. A moment later, without a cover, the patient had left exotropia of about 25 degrees, and then she had right exotropia of 25 degrees. This is the patient 2 days post-operative with orthotropia in the primary position. And this is the patient 1 month post-operative with orthotropia in the primary position. Here is a video of the patient after 1 month from the surgery with alternate cover test. As you can see, the patient is orthotropic. She has exophoria. The patient was satisfied with the result, but in intermittent exotropia, we mean at overcorrection. So the patient was orthotropic from the 2nd day post-operative, and the patient is myope. So I told the patient she has to wear her glasses to maintain the alignment. But the surprise to me was the surprise for the mother. The mother argued with me because she told me that she didn't want her daughter to wear the glasses, and she did the operation because she didn't want her to wear the glasses. Here is the patient after 7 months. The patient is satisfied with the result, but her mother argued with me till this day for wearing glasses, for letting her daughter wear glasses. Case 3. This is a 9 years old child. This case is a 9 years old child with history of previous squint surgery for esotropia since she was 2 years old. Scar on both medial recti is obvious. Visual acuity was 20/25 bilateral. Refraction was +2.5 in the right eye and +2 in the left eye. The measured distant angle was 55 prism diopter, alternating consecutive exotropia since 2 years. When we examined the patient, we decided to do advancement of both medial recti, and this case was recommended case from one of our nurses, and this is what happened. This is the patient with alternating exotropia with the same angle, nearly the same angle as pre-operatively, after 3 weeks or 2 or 3 weeks from the surgery, and on the left side we could see left cyst over the medial rectus muscle. So 2 complications happened in this patient. Yes, she was a recommended case, and it was a very awkward situation, but we told the muscle we need to reoperate, and after 2 months we did excision of the cyst, conjunctival cyst, resutured the conjunctiva carefully. We did bilateral lateral rectus recession 8 millimeter, and the medial rectus on the left eye. When we removed the cyst, we discovered that there was a scar, a stretched scar at the insertion of the medial rectus. It was first time for me to encounter this case. I'm trying to and here is the patient after the 2nd intervention. My mistake was that the patient had a stretched scar, and the suture had to be taken in the more healthy part of the muscle, and the scar part, the stretched scar had to be removed. This was responsible for the recurrence in the first place and after my operation. So when I read about the delayed consecutive exotropia, I found that the stretched scar causes a delayed consecutive exo, with the rationale that stretched scar is ongoing remodeling with a long-term process. That scar is metabolically active, and scar migration may occur. And I found that it was published in the American Association of Pediatric Ophthalmology and Strabismus in 2000, and Transophthalmol by Ludwig, and they recommended the use of non-absorbable sutures. Case 4. This boy was presented to me after he did previous 2 squint operation, and as you can see, he has residual esotropia in the right eye, about 45 prism diopter. He had full ductions and versions, and the dominant eye was the left eye and the non-dominant was the right eye. This is a 12 years old boy who has alternating residual esotropia of 35 prism diopter, mainly in the right eye, with history of previous 2 squint surgeries in both eyes. On examination, scar was found to be on both medial and lateral recti in both eyes. Refraction was -3 in the right eye, -2.5 in the left eye. I asked the mother for previous picture of the patient because the mother gave me vague history, and I told the mother we had to do exploration of the medial recti, re-recession if possible, and re-resection of the lateral rectus in the right non-dominant eye. And I told her that the result can't be guaranteed, and it was the 3rd intervention, so it was very difficult to tell the patients if something happened that we would need 4th time intervention. So we re-recessed both medial recti 2 mm, as they were recessed only 4 mm, and we did resection, but unfortunately the patient was asleep when I came into the operation room, and I worked on the resection on the left eye, not the right eye, as you can see in the picture post-operative. Here I worked on the medial and lateral rectus of the left and the medial rectus on the right eye, and I was very worried because the patient in the 2nd day post-operative, he still has esotropia of 15 degrees in the right eye, which were non-dominant in the first place. And I told the mother that I would work 2 muscles in the right eye and not the left eye. So I left the patient till the next follow-up, and the surprise was that the patient is successfully aligned after in the 2nd follow-up after nearly 1 month. Case 5 and the last case is a very distressing case, so I left this case for to be the last case. A female patient, 28 years old, was presented to us as an emergency. She complained of severe pain, complete loss of vision in both eyes. On examination, the right globe was completely displaced down and laterally and hanging over the lower lid. The left globe was found to be displaced anteriorly, and the posterior part of the globe was caught tightly between closed eyelids. Patient was in a state of nervous shock and weirdly speechless. She was conscious. On examination, the visual acuity was reduced to no perception of light in both eyes. The intraocular pressure was moderately raised. Lids were severely edematous and ecchymotic. The conjunctiva showed profound hyperemia and ecchymosis with dark necrotic patches. The cornea showed signs of exposure, keratopathy, and was edematous at the same time, which perhaps suggests anterior segment ischemia. The pupil was dilated and area active. The anterior chamber was normal depth and contour. The central fundus couldn't be visualized clearly due to cloudness of the cornea. The ocular motility was severely restricted. This was the most shocking and distressing, miserable case I have ever encountered, especially when you know the cause of the severe ocular trauma. The cause was physical assault by the husband. During quarreling, he extracted both her eyes with the finger after she lost consciousness. This is not a picture from a horror movie. This is the picture of the patient. As you can see, both eyes are extracted with the pupil dilated and area active, and the cornea is clouded with necrotic patches. Investigation, it was the first time to me to encounter such case. Investigations, we ordered an MRI to assess the optic nerve and the ocular muscles, but the patient had a CT. This is the CT of the patient. As you can see here with the red arrow, the optic nerve is transected bilateral. All the recti muscles are transected. Only the oblique muscles in the left eye are the remaining muscles. So what to do? What do you think is better for the patient? Enucleation for fear of life-threatening neurological complication as orbital infection and meningitis or phthisis bulbi, or globe salvage for 2 advantages: that the patient will not sacrifice an organ. Secondly, if she had ocular prosthesis, it will be with better ocular motility due to the ocular muscle. If the ocular muscles, we succeeded to maintain the ocular muscles, which greatly decreases the psychological impact on the patient and her family. So after discussion, we decided, this is the patient in the operation room, we decided to do, to try to salvage of the globe. So I did cansotomy and cantolysis, and I tried as much as possible to resuture the muscle if the stump and the rest of the muscle was present. Unfortunately, the medial and lateral recti on both sides were cut, and I couldn't find the rest of the muscle, so I sutured the stump to the periosteum with non-absorbable sutures, and then I finished with tarsorrhaphy. This is the video of the patient, 2 weeks post-operative. I know I was very frightened from this area with no vascularization in the right eye, but the patient maintained some ocular motility. This is later. Two months post-operative. As you can see, the patient could move her eye to the right and to the left, but there is an exotropia in the left eye. The family were satisfied with this result. Following trauma, the most commonly injured or avulsed extraocular muscles in decreasing frequency in the medial rectus, the inferior rectus, the superior rectus, and obliques. Posterior part of the globe is caught tightly against closed eyelid due to contraction of the orbicularis muscle. The surprise was that the patient dropped the charges against her husband, who did that, and complained the emergency doctor, who claimed that he treated her bad. Conclusion. Ego is 1 over the knowledge, so the more knowledge, the lesser the ego, the more ego, the lesser the knowledge. This is a quote from Albert Einstein. Thank you.
شكرا دكتورة هبة، يعني هي بتحييك على المجهود الكبير اللي عملتيه مع الحالة الأخيرة دي. ده يعني حالة صعبة جدا، مجرد مواجهتها في حد ذاته. طب جوزها وصل لإيه دلوقتي؟ اللي هو عمل العملة دي. جوزها وصل ليه يا دكتورة هبة دلوقتي؟
والله انا ما اعرفش هو وصل ايه، بس هي قالت لي ان هي اتنزلت عن الدعم.
ماشي خير يعني. نجرب يعني هنعمل ايه؟ شكرا. بس ليا سؤال للدكتور ابراهيم واساتذتنا في الاسترابيزماس. احنا في البوست اوبراتيف ما بنعمل على العيان عمليه حول، لقيت ظبط خلاص بقى